Hello, welcome everyone. We're very excited to have you here. I'm Kathy Pugacheski. I'm the Executive Director of AHRD, and we're thrilled to have over 100 people who are registered for this first ever virtual town hall today. Folks are coming in the room right now, so we're going to start in a minute here. I'd like to thank the AHRD Board of Directors and the President, Laura Bierma, for putting this together for today to have a conversation and discussion around important topics and AHRD's role in those and how we can serve in this area. So a couple quick announcements. If you could mute your speakers, that would be great during the presentation. If you have questions, put them in the chat. We are recording the session, and we will be putting it on our YouTube channel after we edit a little bit on the front end and the back end of this session. And next week we will be having a Facebook Live session, our first one as well, which President Bierma will be leading as well, and we're going to learn how to do that this afternoon. I am so it's a great time of learning and video and new ways of thinking, and I couldn't think of a better group that will be able to lead our world through change and transition and transformation than this group that we're with right now. So with that said, I'd like to welcome and thank President Laura Bierma and have her start this session off.
Great, thank you so much, Kathy. And it's wonderful to see all of our friends and new friends popping up here in the town hall. And this is the first time we've done this, so thank you for joining us. If you are new to the Academy of Human Resource Development, we are devoted to helping organizations address learning, change, and development broadly. And you can learn more about us. We'll put our website up at some point during the town forum today. We live to lead human resource development through research and are very devoted to bridging research to practice. So in the age of the pandemic, it's forced an immediate transformation in how we live, work, learn, and communicate. And so some of the questions the board has been asking, and my colleagues at the University of Georgia, where I'm a professor, is how can we respond in this time of uncertainty? And how can we create a new, quote, normal, where perhaps we don't go back to the normal ways of being and working that weren't working very well? And how can we lead and learn remotely and protect diversity, equity, and inclusion in these uncertain times? And finally, what should we be researching in this moment? So I'm really proud that the Academy of Human Resource Development had its conference in the Americas in late February amid a lot of trepidation about whether we should go forward. And we did. I think if it had been a week later, we would have canceled it. But at that meeting, our board did approve a COVID-19 statement of support to our colleagues worldwide, and you can find the full statement on our website. But I want to, on behalf of the board, extend our support to all of our friends and colleagues and your families who are affected by this. And we're certainly concerned for the global health and well-being of our community. And we also support evidence-based approaches to solving these problems and restoring our health and community to back to business, I guess. So today, our brief agenda is, we've already welcomed you. We're going to learn about COVID-19 from a medical expert for a brief part of the agenda, and I'll introduce him in a moment, and then reflect and converse about how the pandemic changes the game for HRD. And I've invited a couple of our board members who I'll introduce at that time to lead us in that discussion. And then we'd really like to invite the community to let us know how you would like us to go forward with next steps with future webinars or town forums of this type. So with that, I want to introduce you to Dr. Mark A. Bell. And Mark is a medical doctor, and he did his medical training at the University of Michigan, including his residency training and graduate work in biostatistics and epidemiology. He is a professor at the University of Georgia, and he is in the College of Public Health in the Department of Epidemiology. He's also a respiratory expert, and that's what he does a lot of his research in. And he's been very involved in his local community, helping the government figure out good guidelines for sheltering in place and so on. And so without further ado, I'm going to turn things over to Dr. Abel to make a few remarks. And then if you do have questions, particularly medical questions, he'll be online with us for probably about 15-20 minutes to answer them, and you can put them in the chat. Mark.
Thank you, Dr. Birma. Or I'm sorry, President Birma. I want to get that straight. So yeah, my name is Mark Abel. Thank you for all joining us today. I see a few familiar faces and names there. I am a professor of epidemiology, and a lot of my work in the past 10 to 15 years has been around acute respiratory tract infections and influenza. And we've repurposed, and we have a large ongoing study at multiple sites. We've repurposed a lot of that work now to look at COVID-19. We just started gathering data in Atlanta. We are in the process of putting together a consortium of 7 or 8 major universities to study, what we're trying to look at predicting who's going to have a bad COVID and who's going to have a mild COVID at the beginning. What I wanted to do, I wanted to make you aware of a couple resources first, and then I've got maybe a few minutes worth of comments and just general information, and then I'll take questions. Laura, do you mind if I share my screen? Let's see, Chrome. So this, one of the things I do as a side hustle is that I am the editor-in-chief of Essential Evidence, which is an online reference from Wiley-Blackwell primarily for primary care, emergency, and hospital-based physicians. And we have written very quickly, in fact, I was the author of very quickly a new chapter on COVID-19 that went live a couple of weeks ago, and we're updating it weekly. I convinced the folks at Wiley to get it out from behind the paywall. So if you go to essentialevidenceplus.com and you just click on this link here, it'll take you to the COVID-19. And then there's tabs down here. This is background information, prevention, diagnosis, treatment, prognosis, and lots of links to directly research reports and things like that. What's happening with COVID-19 is very different from any other experience I've had in medical research. It normally takes a year to a year and a half to go from an idea to gathering data. It just took 5 days to do that. So everything is happening on a very different scale than we've ever seen before, which is fantastic and really, fills me with good thoughts and feelings for all the people around the world who are working so hard on this. So you can go to this site. We update it weekly. Usually it goes live, the new update, on Wednesday or Thursday. The other thing I wanted to share with you, each of your state Department of Public Health, if you just Google Georgia Department of Public Health COVID or Missouri or whatever, pretty much every state has its own tracking site. So you can see new cases daily in your county. This is a site from the Institute of Health Metrics, I think it is called, it's IHME, and it's out at University of Washington, and they're probably the best modeling group. And these models you hear a lot about in the news, and they are estimates. They are guesses at what will happen based on what has happened to date. They depend a lot on what you all do and what we do as a community. This is showing the basically hospital admissions is that dotted purple line. And what it shows us is the range of what could possibly happen. The worst case up here is we might need 220,000 hospital beds at once. The best case, we might need 40,000. That's a big range. And so it really depends a lot on the accuracy of the model, but also, are we distancing or not? The top of the range is not distancing. The bottom of the range is really aggressive distancing. That is probably the most important thing we can do. So I think that's a good site to go to. You can also drill down to different countries, regions within countries, and states. And it often looks quite different for different states. So you see Georgia is going to peak a little later on average than the rest of the country. May have to do with the fact that our governor shut down the state later than other states like California. Let's look at California just by comparison. And they had a much earlier, significantly earlier and lower peak. Okay, so this is, and again, they did aggressive social distancing much earlier than many other places around the country. So I think this is a useful site. We've done our own homegrown site where we're tracking new cases per day. And one thing that we saw was that where in the blue line here, which is our county, you want to see this blue line go up. That means it's taking longer and longer for the cases to double. Call that the doubling time. So if it's taking 14 days or 10 days for the number of cases to double, that's better than 3 days or 4 days. And the red line is the counties around us. They started distancing aggressively here, and we're starting to see some benefit. We started back here, and we, basically outpaced them and are doing a better job locally. So we are seeing, I just want to impress on you, this distancing is very real and a very important part of control of this pandemic. So let me just switch back to off the page there, or I can just leave that up if you want. Or actually you can't see that, never mind. I'm gonna stop the share. And okay. Every time I get into one of these, I feel like I'm either on the Brady Bunch or Hollywood Squares. I'm not sure which one. That tells you how old I am too. I see smiles from some of us who are old enough to remember that, and perplexed looks from others. So in any case, the cases in your, so one way to think about it, so COVID-19, coronavirus disease, started in 2019. That's where the name comes from, in case you didn't know that. One of the things to keep in mind, if you hear that there are, for example, 70 confirmed cases in Clark County, Georgia, there are probably, the modelers estimate, probably 10 times as many undetected cases. So, take whatever number you see locally and multiply by 10. That gives you a better idea of how many cases there are. And it may be much higher, it may be lower. Again, these are estimates. We will know the answer in 6 months, probably, maybe in 3 months, we'll have some idea, but we don't know that right now. So the confirmed cases right now are people who got a test result back. It is currently still taking up to a week in some parts of the country, many parts of the country, to get a test back. So what we know now is the number of cases a week ago, basically. And so, that's why we're getting a very imperfect look at this pandemic. It is highly transmissible, including by asymptomatic people. And that has been known for a while now. And these asymptomatic persons, it appears for like 48 hours before they start developing symptoms, they can transmit the virus. So somebody inhales some virus, they then have typically a 3 to 7 day period, averages around 5, before they start developing symptoms, if they do. About a third of people never develop symptoms, maybe 20 to 30% never develop symptoms. About half to 60 to 70% have a mild to moderate illness. They feel crappy, but they can, they're able to function. They don't need to be in the hospital. About 15% end up in the hospital on oxygen. About 5% end up in the intensive care unit, and about half of them die. The death rates predominantly or disproportionately affect those who are older. Beginning at around age 50-ish, you start to see significant increases in mortality rates, which are for people in their 60s on the order of 7 or 8%, people in their 70s around 10%, and higher for people in their 80s. That's a very bad infection. By way of comparison, seasonal influenza has an overall fatality rate of infected people of less than 1 in 1,000, less than 1/10 of 1%. And we're talking fatality rates of 1% overall for this virus, and 2, 5, 10, 15% for those who are older or more vulnerable. It can be transmitted by those asymptomatic people. We have that data from Singapore. They do really, really good contact tracing. And early on, they identified 3 clusters of infected people and every single contact, and they were able to trace back to where each of them caught it. And in several cases, about 7% of cases, their contact was with somebody who later developed the virus and symptoms of the virus, but at the time they made contact had no symptoms. And we've seen that also in other reports and other settings. So it is possible that somebody walking down the street feels perfectly well, could still transmit it. We think it's a minority of transmissions. We think most transmissions occur from expelled droplets. The virus gets on a little tiny droplet, and that droplet can travel about 6 feet with a good cough. And we think that that's where that 6 feet distancing comes from. It's from studies of influenza, where they basically saw how far those droplets travel. I'm getting a little feedback from somebody. Thanks. So surfaces can also hold the virus. It's a sticky virus. Most viruses don't live very long on surfaces. The laboratory studies show it can live on cardboard for about 24 hours and on glass, steel, or plastic for 72 hours. Now, we don't know in real world conditions how much of the virus do you need on a surface to infect you? Whether you get any illness, a mild illness or a severe illness is associated with how much of the virus you are exposed to. A big exposure, more likely to develop the infection, more likely to have a severe infection. A very small exposure, you might have no infection at all or only a mild infection. We do have immune systems and they can deal better with smaller viral loads. So I think if you think in terms of surfaces, the safest thing to do if you're ultra cautious, and particularly for those who are vulnerable or who are immunosuppressed, being ultra cautious makes sense. I would much rather go back 2 months from now and say, gosh, Mark, you overreacted, than gosh, Mark, was good to know you. Okay, so I'd rather be a little overcautious. As Anthony Fauci said, if people think you're overreacting, you're probably barely doing enough. So the most cautious thing to do with surfaces is to assume that surfaces are contaminated. And for example, when we get packages delivered or mail, it goes onto a bench and it sits there for 24 hours. Let time be your friend. There's no mail I've ever gotten that can't wait 24 hours. Other surfaces you have to clean. 60% or more isopropyl alcohol is what we use. Not all cleaners meet those criteria. A dilute bleach solution will also work. In terms of those surfaces, the way I think about it, if the FedEx guy gets out of his van, coughs several times on my mail, hands it to me, I touch it and touch my mouth, that would worry me. I think the risk of other kind of surface exposures are relatively low, but not zero. So, that's kind of your judgment. We have a decontamination routine in our home. I just told you what we do with non-perishable groceries and mail and packages. Perishables, we sanitize our hands. We put them in a dirty zone on the counter. We use 60% alcohol spray and wipe everything down without touching face or mouth. And then we move each cleaned package to a clean zone, and then it goes into the fridge. Sounds nuts, but that's what I know about sterile procedure. And I want to take I'm a 58-year-old with asthma. I want to be careful. I don't want to take any chances. It is very hard to train yourself not to touch your face. I'm sure many of you, while you've been listening, have touched your face and didn't even realize it. We get training in medicine mainly when we're on surgical rotations. When you're scrubbed into surgery, which takes 10 minutes, by the way, to wash everything and scrub in, if you touch your face with your gloved hand, you leave the room and re-scrub if somebody catches you doing that. So you're highly motivated to not do that, and you just learn to sort of train yourself. And a lot of healthcare professionals can do that fairly well. I've had a conversation with an intensivist in Detroit who's dealing with this on the front lines. And, she just said, yes, I do not touch my face once. I don't eat with my hands, period. These are people in high risk situations. In terms of the diagnosis, so that's kind of talking about prevention and surfaces and how it's transmitted. In terms of prevention or diagnosis, most patients have fever, but not everyone knows they've had a fever. A lot of people, I've had talked to patients, I'm still seeing patients telemedicine wise, and they say, oh yeah, I had chills or sweats, but I don't think I had a fever. If you had chills, that's coming down from a fever. And it is highly likely you had some fever. Some people are relatively insensitive to the sensation of feeling warm. Others are very sensitive. So measure your temperature is more reliable if in doubt than just relying on your own body's ability to detect it. So fever is very common. Cough is quite common. Shortness of breath out of proportion to the cough. The cough is often dry and not necessarily producing phlegm. Some patients have other symptoms, sore throat, runny nose, body aches are common, and some patients have GI symptoms, diarrhea, things like that. The PCR test is the test that we do to detect a current active infection. That's where they stick the swab up your nose, kind of like they do for the flu test, and it detects viral particles in very low numbers. We don't know yet exactly how accurate those tests are. They've always been the gold standard, but we're seeing that some patients early on have a negative test, a normal test, but then a few days later, while they've been sick all the time, it turns positive. So, we are a little uncertain what a negative PCR test means in somebody. A lot of places are requiring 2 negative tests 24 hours apart before saying you don't have it and you can return to your normal activities, for example, for healthcare workers.
Mark,
There are
there's a
also,
couple of questions that might pertain to that as far as how
sure.
time frame for recovering. I'm just looking in the chat after catching the virus, which seems kind of relevant to that point. And there's a couple more in the chat.
Okay, yeah, sure, I can, let me see if I can look at that. So in terms of the recovery, it varies a great deal. Many patients have a relatively brief illness where they're symptomatic for 7 to 10 days. Patients with a more severe illness have a more prolonged illness, a longer illness. If they're hospitalized, in the Chinese studies where they had the first experience, the average, if somebody was hospitalized, so they had a pretty severe infection, lots of virus, they were shedding virus for up to 20 days on average, and the upper end was around 35 days. So people can shed the virus for quite a while. That's one of the things we're not completely clear on, is how long does someone remain infectious? The guidelines from the CDC say once someone, a healthcare worker, has stopped coughing for 3 days and has not had a fever for 3 days, and ideally has 2 negative PCR tests in a row, they can go back to work. And let me see, is there a known time frame for recovering? Do we have information how fast? So how fast the virus is mutating? Viruses mutate like crazy. They are very sloppy in how they reproduce. And when they do so, errors get entered in. I saw a report, this was a couple of weeks ago, that was in the journal Nature, I believe, that it's mutating relatively slowly compared to other viruses, which is good. We want it to mutate, we know they'll mutate, but it's mutating relatively slowly. That means that any immunity is likely to be more long lasting and makes it easier to develop a vaccine, perhaps even a one-time vaccine. Right now, we're not sure if we're gonna have a one-time vaccine like measles or a seasonal vaccine due to mutations like influenza. I've heard about, so have you heard about high doses of zinc and quinine helping in combating coronavirus? As long as you mix the quinine in a gin and tonic, I fully endorse it. But I've heard lots and lots of reports, and I can maybe shift and talk a little bit about some of these treatments. Quinine was a treatment for malaria, and I think where that came from is that other treatments for malaria like chloroquine and hydroxychloroquine have been promoted, over-promoted. I'll say very clearly they've been badly over-promoted, and we should be very cautious about believing that they are effective. I think there were some studies done in vitro, like in a test tube Petri dish, where they exposed some of the original SARS coronavirus from 10 years ago, the one in Hong Kong and Canada, to hydroxychloroquine, and it slowed its growth. And that turned into, oh, it's a treatment. There have been a number of trials done now, short, kind of, we call them LCS is the technical term in evidence-based medicine, little crappy studies. And they have taken like 20 patients that weren't really randomized. There was one study that claimed it was effective because it reduced the hydroxychloroquine patients had less virus in their nose, but they excluded 3 out of the 14 that went to the ICU and 1 that died. So they excluded everybody that had a bad outcome, and they said, look, we had a good outcome in these other 10. And meanwhile, in the comparison group, nobody died or went to the ICU. So it's a drug also. I'm getting involved in another study with a cardiologist here that in about 10% of patients dangerously lengthens what's called your QT interval, which is part of your heart's rhythm mechanism, and can lead to fatal arrhythmias. We've had patients who died already of this. We're monitoring this. Anybody taking the drug is on telemetry. It is being widely used in hospitals because we have nothing else. Patients are being put on a cocktail of hydroxychloroquine, azithromycin, sometimes zinc. Zinc does have some antiviral properties. The better the study, the less the antiviral properties appear to be, but it may have some. It's probably not harmful. Azithromycin has been around a lot. If we're giving it to everybody on the planet, it will cause a lot of bacterial resistance, which has its own problems. It's an antibacterial. It has no antiviral properties. It's probably, if it has any benefit, it's in preventing a secondary bacterial infection in people. So I think I would not count on, there are also reports that patients taking an ACE inhibitor or an ARB, drugs that end like a losartan, candesartan, anything ending with a sartan or april, lisinopril, those are the drugs for hypertension and heart disease, that they have better outcomes. There have been some reports, and there's some theoretical basis for that. But again, this is all very early days. There are a number of antivirals that are being tested. that's very promising to me, antivirals. These are drugs that target what are called RNA viruses, and this is an RNA virus. So if we're going to see some benefit, I'm hopeful. Remdesivir is one of them that's being fairly widely tested. The good news is that we will have answers to a lot of these questions about, there are 23 trials underway on hydroxychloroquine in China alone. There are a number in the US already. We will have the answer quickly because these trials are up and running, recruiting patients, and within a month of recruiting a patient, you know if it worked or not. They either did better, they survived, or they did worse and perhaps died. And so the good news is we can do these studies and get an answer in a month or 2 months, not in 5 years like for heart disease or cancer or stroke. So that's the good news, is we should have a pretty good idea. And if we can flatten that curve, and here's where I think the last thing I wanted to talk about, and then more questions, is, what do I expect will happen? I mean, if you go to the IHME tracker, it looks like in most places, the number of hospitalized patients, which is about 10% of the confirmed patients, which is about 1% of all patients probably who have the infection, that percentage is, that number is going down by early June. And so hopefully through late June, July, August, we may have a period of relative normalcy with continued monitoring and then watching for another outbreak. This probably will end up being seasonal, it looks like, kind of like the flu. It isn't right now, and the warm weather is not helping. Trust me, this is a new virus in a bunch of new susceptible hosts, and it doesn't care what the weather is. But often these do take on a seasonal pattern over time. So I think we'll see flare-ups in the fall, and the challenge will be how well will we manage those flare-ups? Will we be able to rapidly test, rapidly isolate, contact trace, isolate the contacts, and squash it early, these little flare-ups that are going to be happening around the country. That's, I think, going to be our challenge in the fall, which is very different. By then we should have some idea perhaps of some treatments. We should have hopefully more ventilators that are going to be coming online in June and July. They'll be available in the fall. So it's going to be a very different challenge in the fall, but it's still going to be a big challenge. Just think if there are any other questions. And Singapore is 25 kilometers in radius. Yes, Singapore is a closed autocratic society. So they follow rules really well. So contact tracing is a lot easier there than it is in Georgia, bless our hearts here. So it's tougher. We have a very different culture, very different society, and very different structure. So yes, but they moved early and they tested very widely and they did a good job. And let's see, any other questions?
There are a few more in the chat. So why are African Americans dying in greater numbers?
Yeah, good question. There are a lot of things, there are a lot of moving parts here. Certainly one is higher levels of comorbidity, so higher rates of heart disease, asthma. Asthma is more severe often in African Americans, and chronic lung disease is more severe. There are social determinants of health that play into that, as well as, there may be some genetic factors around severity of asthma, but I think a lot of it has to do with social determinants and access to care. Part of it will have to do with how many people have been tested. Right now, as I said, there's many, many more cases. If you have relatively less testing in a community that has less access to care, those cases who do rise to the surface are going to be the sickest. And so that may be what's going on, is that a higher percentage of the confirmed detected cases appear to be serious. What we have to look at later on when we have all the data is per capita numbers, per 1,000, per 100,000 people. Does it still look like that? It may not. It's kind of too early to tell. In fact, we were involved in a study right now. We just got a study where we're gathering data in a federally qualified health center in the Atlanta area, where the majority of the clientele are African American. And so we're going to be hopefully contributing to some of that data. Starting to read this is more like high altitude sickness as opposed to pneumonia. I think what I can say, it is clearly a pneumonia, but it's different from the typical community acquired pneumonia. It causes kind of a diffuse, patchy infiltrate, we call it. So the entire lung is diffusely involved. In a typical community-acquired pneumonia, you have one lobe or one section of a lung that's very badly involved. And with this more diffuse, you tend to have more of a dry cough. And it looks like the patients, and I've had docs caring for these patients say they don't look as bad as their numbers then look. Then they have an oxygen saturation level that, which is a measure of severity that is much worse than they would have thought. So they're just not exchanging oxygen. The entire lung is impaired in its ability to take in oxygen from the air and get it into the blood supply that gets it to the rest of your body.
One question you might appreciate is, how has your work been disrupted?
It's strange. I was pretty ready to go online with my class. I teach a class in clinical epidemiology, evidence-based practice here at the College of Public Health, and the students have been great and flexible. But what it's disrupted is all of a sudden I'm involved in a Gates Foundation study. I'm getting this multi-center study up. I'm involved in probably a half dozen studies. I'm also wrote this chapter, updating it. It has just consumed my professional life, and probably will continue to do so for the coming month or two. But it's also a way that's very satisfying to say, okay, finally, a few people appreciate epidemiologists more than they used to, and understand the importance of this public health infrastructure that we have and supporting that. And hopefully, and I think also as a clinician, I went from seeing my patients, I've never done a telemedicine visit in my life. And now I've done 4 weeks of them. And it's remarkable. It's different. I can actually have, in some ways, not as good of a conversation or contact, but in other ways better. And I can actually, I'm spending a little more time with each patient. I'm able to ask them questions and get responses that are different. So I think it's changing, and I think it's going to change how we deliver healthcare in this country. I think we're going to be much more open to telemedicine and telehealth for all of us going forward. I think that's going to be transformational.
And perhaps time for one last question, and this is the one that's at the bottom of the chat, is what can the average person do to end this crisis as soon as possible? And how do we make a difference?
Can I say stop listening to Donald Trump and start listening to Anthony Fauci? I think, this virus doesn't care how old you are, who your friends are, whether you're a Republican or a Democrat, it just doesn't care. And so the only thing we can do is to be as adherent as we possibly can to physical distancing. And I would say one of my friends, Aliki Nicolaitis, I don't know if some of you know her, but she said, physical distance, but social closeness or something like that. But, I think we need to be socially as close as we can, even while we remain physically distant. And I think one other thing people have a lot of confusion about is masks, and there's a lot of confusion among physicians as well. When you are seeing somebody with suspected COVID, you put on an N95 respirator mask, a face shield, a gown, a cap, and gloves. That's a very different level of protection from a cotton mask. Now, I just saw a study in Annals of Internal Medicine. If you're going to make a homemade mask, it's actually about as good as a surgical mask if you have 2 layers of 180 thread count cotton, think good sheets, basically good quality sheets or pillowcases, two layers, maybe 3 layers of that provides similar protection. Now, the protection is for those around you. Wearing a mask like that in public, or even a surgical mask, does not protect you at all, okay? The virus is very, very small. It's smaller than you can imagine. It's smaller than anything you can imagine, and it can easily make its way to the virus. This is what the fibers look like on a mask. They're huge. They're just big gaping holes everywhere. It can easily get through. So masks are intended to catch the droplets that you cough out or breathe out and keep them from getting on your friends, your family, anybody in the store you may be near. They are not to protect you. They're to protect those around you. And so that's, I think, an important point. We don't want to be getting a false sense of security. And one concern about the masks is that if everyone wears them and still does all the correct physical distancing, great. I don't think they're going to do harm. But if you think it's going to protect you or make you immune from the need to physically distance, I think that's a huge mistake, and that could do harm. Okay.
Well, I know you are a busy person these days, Dr. Abel. So I want to thank you for your time today, and we really appreciate your informative updates. So
Hey,
thanks so
thank you.
much.
Been a pleasure. Take care.
Thanks. Bye-bye. All right. Well, that was a really wonderful update from Dr. Abel. And so moving on with our agenda, I invited two of our wonderful board members to reflect with us on a question. And so I'm going to ask Drs. Tamiko Greer and Robert Yawson to, in a moment, introduce themselves. They are on the board and they are wonderful researchers and scholars and practitioners of HRD. And they're going to help us reflect on that. And I'll probably also add in some thoughts. And then we will welcome comments and questions in the chat area. And then toward the end of our agenda, we're really interested in how we can best serve the HRD community in the future. So if meetings like this are helpful, we are really happy to do more of them. So with that, why don't we turn things over to Tamika? And if you would introduce yourself briefly and share your thoughts on how is the pandemic a game changer for HRD? You're muted. Dr.
Is that better? Is that better? Is that better? You can hear me now? Okay. Thank you for that introduction, Laura. For those of you that don't know me, I am Dr. Tamika Greer. I am a board member, as Dr. Bierma mentioned, and I am a faculty member at the University of Houston, and this is Houston behind me. It's not really, I'm at home, but I have the picture. So when Dr. Bierma asked me to share my thoughts, I wrote them down so that I could remember what I wanted to say. So I'm going to share those with you. Maybe. Okay. So the question on the table was, how is the COVID-19 pandemic a game changer for HRD? And when I'm reflecting on that, I think of this in terms of two different areas. So we have this whole idea of physical distancing or social distancing, as we hear it called a lot, where we're being encouraged to stay away from each other. And what happens when we do that, or what has happened when we do that, is that we're seeing that the way people work is now changing, right? So our workforce is more dispersed. We're doing a lot more technology mediated interactions, such as the one we have here. It's also changing the way people learn. And when I say people, I'm talking about, from birth all the way up, because we've got, daycares closed, we've got kids out of school. I think even, at the higher ed level, I know that, nursing students are not able to, do their internships. We've got teacher or people studying to be teachers who aren't able to do their student teaching. So internships. And then even as professionals, the way we receive our training and development opportunities is changing as well. And I also think we're seeing a change in what we perceive as a highly valuable job or set of skills. And we've heard this dichotomy probably over the last 2 weeks has been developing in terms of who is an essential worker. And then of course, the opposite of that would be a non-essential worker, right? And so we're seeing that essential workers include very highly skilled people. So people in the healthcare industry maybe, as well as very low skilled jobs. So, the people who are checking us out at the grocery store and those sorts of things, and picking up our trash, like those are generally considered lower skill versus also the higher skilled people. And it's kind of funny that those of us in the middle, neither super highly skilled or low skill, are tending to be laid off, right? And furloughed and that sort of thing, right? So there's that physical distancing aspect of the pandemic that's changing the way we work, the way we learn, and what we see as essential versus non-essential. And then I think there are some aspects of the virus itself and the actual infection. And what I see that doing is really exposing structural disparities, especially right here in the United States, and inequities. So we see this in terms of who has access to testing, who has access to the best healthcare, We're seeing that, and I know one of the questions earlier for Dr. Abel was about why we see more African Americans dying. Well, part of that is the types of jobs that we tend to be concentrated in. And so that also shows some inequities or is highlighting, exposing some inequities there too. And even also in technology access, those of us that can work from home, those of us that can learn from home, there's a whole nother segment of the population that does not have the access and resources to be able to do that kind of thing. And so what I think the virus itself is doing is putting out a call to action, especially for us as HRD professionals. And some of the things that we need to be thinking about is how all these changes based as a result of the physical distancing as well as the virus itself is requiring us to rethink how organizations work, how people work together in organizations, how teams are managed in organizations, and then the actual work that we do as HRD professionals, the coaching, the management of people, the training and development. There are impacts for how we need to do that differently and what different aspects of those jobs need to come to the forefront. I also think we have to think more about people as holistic people, because right now people's work lives, people's home lives, people's personal lives, there's so much blurring of that right now. And so that requires us as HRD professionals to think of the person as a holistic person, not just an employee. Okay, but I do think also for those of us who maybe have a background in instructional technology or an interest there, it does open up a lot of opportunity for technology advancement, including distance learning. So I'm going to wrap up my time with remembering that our recent conference in Atlanta, the theme of that conference was actually inclusion and activism in an age of intolerance. And I want to, I feel like that was almost a foreshadowing of what was to come in the coming months. That idea of inclusion and activism, meaning we care about all people and we act, right? So we're not a passive group of people, but we are acting in this age. And I think there is a call to action based on this virus. So that is what I wanted to share today. And I guess I'll turn it over to Dr. Yalson. Is that right?
Thank you, Tamika, Dr. Greer. And now we'll hear some remarks from Dr. Yalson. And then we invite you to post your questions or reactions in the chat.
Yes. So thank you. I'm Robert Yalson. I serve on the board and I'm an associate professor of management at Quinnipiac University. So most of the thoughts I want to share, fortunately, Tamika has highlighted on them. And the truth is the pandemic is definitely a game changer for HRD research, and demand for new research and evolving areas of research is becoming a priority for us, and areas which I call underrepresented research areas in HRD are now coming to the forefront. And as researchers, we should look at where we really now have to spend our energy in doing that. Tamika mentioned work. The world of work may change forever, and more research will be needed in remote and virtual workspaces. It's something that is being done, but now we see almost the entire world is working remotely, and it's calls on us to do more research, especially when it comes to our research with engagement at workplace and the meaning of work itself. How do we look at engagement virtually and people working from remotely? How is work engagement look at? And there are new taxonomies and research themes that are evolving. Politicians are throwing terms around. There are issues that are coming. How are we actually defining these terms? We need research around. When we talk about social distance or physical distance, we need boundaries as to what we are really talking about. What is social distancing? Now it's just a term that is going around, but we need research into areas like that and how it affects the way we live and the way we work. We talk about essential and non-essential workers. How does that alone affect motivation at work? Whose responsibility to categorize who is essential worker and who is non-essential worker? And are the terms even right? Whose work is not essential, and who determines that? Those are things as HRD professionals we have to look at and give some empirical thought to it. And how do we incorporate more of like scenario planning into HRD research? How do we plan ahead instead of being reactive? How do we become more proactive to offer our resources when pandemics and disruptive things like that happen? We don't have to be reactive, you just have to be more proactive. And I think scenario planning and other forms of research that are more predictive will need to be areas HRD will look at. We might start to modifying terms like 21st century skills into post-pandemic skills and disruptive skills. So there are so many areas when we talk about critical HRD research, like Tomika mentioned, we need to be more systemic. Health disparities, what is happening with the COVID in the African American community, and the systemic nature is just not the morbidities and others. Poverty, income inequality, and everything that are underrepresented research in HRD are areas that now stares us in the face. What are we going to do? And K-12 education and higher education in general, how are we going to react? Parents now are coming to grips and understanding more of online education, distance learning, and more companies will come out of this where people will be working remotely. What do we do even with these fiscal burdens and etc.? Things that are part of our HRD functions, business continuity plans, flexible work arrangements, and employee communication. And the last thing I want to talk about is like volunteerism. We see how volunteerism has become very important in this, and it's one area that we don't do well at all in HRD research. How do we look at that? So the whole pandemic as a distraction has presented an opportunity for us as HRD professionals and researchers to look more into new areas of research. And I think I'll end it here, and then questions come, we all discuss. Thank you.
Thank you so much, both Robert and Tomika. We do have some questions in the chat, and so maybe we can take a look at those. I have a couple of things I can add, but I think we've got some really great questions. And I think, let's see here. In terms of leading organization development in the wake of business models shutting down, that's one of the questions. And how do we work with a pandemic impacted workforce? And then the second part was, how does HRD address disparities in the remote working world? Any thoughts, panel, or anybody else want to offer thoughts in the chat?
Yeah, so if I can give it a shot, when addressing, it's the way we look at research, or even the world of work, we look at it holistically. Oh, this is how engagement should be. But then at times we should disaggregate it. Who are the type of workers you have? What are they facing? And it's not just about work. They are bringing in all these health disparities, inequalities, and others. So when we are looking at work engagement, we might be engaging, but it's different from how it affects me or how it affects someone else. So we have to broaden the scope of the research and look at individuals before we see look at it collectively. So that's one way HRD can look at disparities and recommend solutions.
Thank you. I came across something in my reading this week that really struck me. And it was put out by Catalyst, which does a lot of work on behalf of women and organizations. And the International Labor Organization is predicting an increase in global unemployment by about 25 million as a result of the pandemic. And the article was really speaking about, when workers start getting laid off, how is that going to affect diverse workers, so women and people of color in particular. And I thought it was really quite interesting that, this is an opportunity for organizations to be more mindful about, sustainability of all jobs and all people, not just the more privileged. And then the article also actually said that this is the first opportunity for us to actually do research in organizations during a pandemic, and especially looking at gender and race and other factors of diversity. So I thought it was also worth us really thinking about is how do we help organizations when they're faced with a crisis, make socially responsible decisions, and after it's over, even if there have been furloughs or layoffs, that they were done humanely and equitably. So I offer that as something to chew on as researchers and practitioners.
So one thing I think about in terms of being able to address these disparities that we see is to certainly bring awareness to them and not kind of sweep it under the rug. So the problem I see right now is that we're only exposing these disparities. They didn't come up now, right? And so the more people who are aware that they exist, right, especially those of us who have resources to be able to funnel in that direction, the better. So first and foremost, we have to be aware of the issues. And I think this pandemic is highlighting that for a lot of people. And then the second thing we have to do is that when we do act in our communities is to be aware that let's not think long and hard about the actions that you take. Don't go with the status quo just because that's how it's always been done, but consider that there are other underserved populations and communities of people that can benefit from your actions, your effort, and your resources, right? And so when you go to, apply for a grant, consider these populations, not just the ones you have easy access to, right? And that's the way we start to address these things and change these things, but it starts with awareness. So it's actually a good thing that people are seeing this because it brings awareness.
There's some really great comments in the margin. And so I encourage Tamika and Robert to see if you want to speak about that. I also want to be mindful of the time, and we said this would be an hour, and we have about 5 or 7 minutes left. And one of the things we would really like feedback on behalf of the AHRD board is this format helpful, and how can we serve our community during this time, and of course into the future. But I think we really want to provide a sense of virtual support and community here. So we would love to get your feedback on that, or any other thoughts we have about HRD in the era of a pandemic. I see one comment of appreciation and hoping we'll continue to do this. And it's a natural experiment indeed. One request for seeing virtual, or to see HRD models presented that are being used or tested. I like that idea. And okay, thumbs up. So as you share your feedback, I would like to just put in a plug that next week we are also experimenting with a Facebook Live session. And that will be on Thursday, the 16th of April at 12 noon Eastern time. Hopefully trying to put it at a time of day that will allow our friends across the world to join us. And I appreciate the global diversity we have today. I've noticed that with great pleasure. So I think too, and I'll put my email message in the chat. If you have suggestions for topics, or if you'd like to see a webinar, I really like the idea of the HRD models. We definitely want to use this forum to upgrade our virtual ability to connect with our community. So I think we'll be seeing more of these, but I will type my email address in the chat box.
I think one of the commenters here brought up a good point about addressing the return, like after the pandemic is under control and we're starting to return to what we think is normal. First of all, I don't believe in any way that we'll return to what we thought was normal 2 or 3 months ago. That's not happening. A lot of these changes, in my opinion, are here to stay. Even my husband was talking about like how his company never allowed people to work from home. Well, now they have been for 3 weeks. And so you can't go back now and say you can't, because you just proved that we can. So the point being that everything is not just going to fit back into what we used to call normal. And this commenter, Deepak, mentioned that HRD will have a role in the after effects or the aftermath and getting people back into a world where we're not mandated to be physically distant. I'll say that. Mm-hmm. And so managing the changes around coming out of this pandemic and going back into a non-pandemic situation. And so there's going to be work implications of that. There's going to be psychological implications of that, and logistical implications of that. And so helping organizations as well as employees navigate what the new post-pandemic world looks like. So I do think we'll have an important role in that.
Mm-hmm. Wonderful. And I see some terrific ideas in the chat, and I would like to assure you we are capturing that as well as the list of attendees. And you may have noticed we are recording this session, so we are going to make it widely available. And some of you may have seen the quote flying around social media that says, when we go back to normal, we need to decide, what aspects of normal we'd like to shed. And I'm holding that as a way of being, I think, now and going into the future, because if we go back to business as usual, then I think shame on us that we haven't learned how to be different leaders and learners in this moment. All right. Doctors Greer or Yasin, any final comments?
I just want to thank everybody for attending. I think this session was a very important thing that we needed to do. Thank you, Laura, for bringing Dr. Abel to talk to us about the epidemiology side of it. That was very informative. And I appreciate all these comments. I appreciate the participation and the many ideas that you guys have. It gives me encouragement and hope that as a group of HRD professionals, we are going to be very well poised to bring some good things out of this pandemic situation, especially in terms of equity and inclusion, and bringing attention to the importance of HRD in times like this. So.
Yes, to echo Tamika's point, it shows how important HRD is and how we are to the community, and how we should not let opportunities that has been presented to us go waste in terms of our research.
Yeah. Thank you. And I see a comment that our work has never been more critical, and I couldn't agree more. And thank you to all of you for taking time today to be a part of our global HRD community. And I hope to see more of you in this forum, and of course involved in the Academy of Human Resource Development. And I want to also thank Kathy and the eWorld staff for helping us on the logistical and technical side today. And with that, I hope you'll join us for our Facebook Live session next week. And my email address is out there. Please get in touch and let us know how we can serve you in this forum in the future. Thank you. And with that, we're adjourned. Thank you.